Dear students, Aslam. In the later part of last lecture, we were studying the use of acid-base nomogram for the diagnosis of acid-base disorders. In this lecture, we will continue with the diagnosis of acid-base disorders. The objectives of today's lecture are to learn about use of anion gap to diagnose acid-base disorders, to learn about diuretics, and to learn about kidney diseases. Use of anion gap to diagnose acid-base disorders. The concentrations of anions and cations in the plasma must be equal to maintain electrical neutrality. Therefore, there is no real anion gap in the plasma. Only some cations and anions are routinely measured in the clinical laboratory. The anion gap is the difference between unmeasured anions and unmeasured cations. It is estimated as sodium concentration minus bicarbonate ion concentration minus chloride ion concentration, that is 144 minus 24 minus 108 equal to 12 milliequivalents per liter. Unmeasured cations include calcium, magnesium, and potassium, while unmeasured anions include albumin, phosphate, and sulfate. Usually, the unmeasured anions exceed the unmeasured cations, and the anion gap ranges between 8 and 16 milliequivalents per liter. The anion gap will increase if unmeasured anions rise or if unmeasured cations fall. The plasma anion gap is used mainly to diagnose different causes of metabolic acidosis. In metabolic acidosis, plasma bicarbonate concentration is reduced. If plasma sodium concentration is unchanged, the concentration of anions must increase to maintain electroneutrality. If plasma chloride increases in proportion to the fall in plasma bicarbonate, the anion gap will remain normal. This is referred to as hyperchloremic metabolic acidosis. If the decrease in plasma bicarbonate is not accompanied by increased chloride ions, there must be increased levels of unmeasured anions, and therefore an increase in the calculated anion gap. Metabolic acidosis caused by excess non-volatile acids is associated with an increased plasma anion gap because the fall in bicarbonate ions is not matched by an equal increase in chloride ions. Let's have a look at the causes of increased or normal anion gap. Increased anion gap is seen in diabetes mellitus, lactic acidosis, chronic renal failure, aspirin poisoning, methanol poisoning, ethylene glycol poisoning, and starvation. While normal anion gap, that is hyperchloremia, is present in diarrhea, renal tubular acidosis, carbonic anhydrase inhibitors, and in Addison's disease. Let's now study diuretics and their mechanisms of actions. By definition, diuretics increase the rate of urine volume output. Most diuretics also increase urinary excretion of solutes, especially sodium and chloride ions. In fact, most diuretics act by decreasing renal tubular reabsorption of sodium. The most common clinical use of diuretics is to reduce extracellular fluid volume in diseases associated with edema and hypertension. The effect of most diuretics on renal output of salt and water subsides within a few days. This is due to activation of compensatory mechanisms initiated by decreased extracellular fluid volume. Many different diuretics have different mechanisms of action and therefore inhibit tubular reabsorption at different sites along the renal tubule. Let's now study some general classes of diuretics, their mechanisms of action and their sites of action in the renal tubule. Osmotic diuretics inhibit water and solute reabsorption by increasing osmolarity of tubular fluid. They mainly act on the proximal tubules. Loop diuretics inhibit sodium potassium chloride co-transport in luminal membrane in mainly thick ascending loop of Henle. Thiazide diuretics inhibit sodium chloride co-transport in the luminal membrane in the early distal tubules. Carbonic anhydrase inhibitors inhibit hydrogen secretion and bicarbonate reabsorption, which reduces sodium reabsorption in the proximal tubules. Aldosterone antagonists inhibit action of aldosterone on tubular receptor. They decrease the sodium reabsorption and also potassium secretion. The site of action is on the collecting tubules. Sodium channel blockers. They block entry of sodium into sodium channels of luminal membrane, thereby decreasing sodium reabsorption and decreasing potassium secretion. They also act on the collecting tubules. Moving on to the kidney diseases, which are among the most important causes of death. Severe kidney diseases can be divided into two main categories. Number one, acute kidney injury, AKI. The kidneys abruptly stop working entirely or almost entirely, but may eventually recover nearly back to normal function. The other main category of severe kidney disease is the chronic kidney disease, CKD. There is progressive loss of function of more and more nephrons that gradually decrease overall kidney function. Let's first study the acute kidney injury. The causes of acute kidney injury can be divided into three main categories: pre-renal acute kidney injury, intra-renal acute kidney injury, and post-renal acute kidney injury. Pre-renal acute kidney injury is the condition that results from decreased blood supply to the kidneys. Pre-renal acute kidney injury reflects an abnormality originating mainly outside the kidneys. Normally, the kidneys receive an abundant blood supply. As long as renal blood flow does not fall below 20% of normal, acute kidney injury can be reversed. The causes of pre-renal acute kidney injury are: number one, intravascular volume depletion, which may be due to hemorrhage because of trauma, surgery, postpartum, or gastrointestinal hemorrhage. Intravascular volume depletion may be due to diarrhea or vomiting or burns. The second cause of pre-renal acute kidney injury is the cardiac failure, which may be because of myocardial infarction or valvular damage. The third cause of pre-renal acute kidney injury is the peripheral vasodilation, which may occur because of anaphylactic shock, anesthesia, or sepsis because of severe infection. Another cause of pre-renal acute kidney injury are the hemodynamic abnormalities, which may occur because of renal artery stenosis or because of thrombosis and embolism of renal artery or renal vein. So all these causes can cause pre-renal acute kidney injury. Now, if the cause of pre-renal acute kidney injury is not corrected and ischemia of the kidney persists longer than a few hours, pre-renal acute kidney injury can develop into intra-renal acute kidney injury. Remember, intra-renal acute kidney injury is caused by abnormalities within the kidney. Intrarenal acute kidney injury can be further divided into small vessel or glomerular injury, tubular epithelial injury, renal interstitial injury. This classification refers to the primary site of injury. The small vessel or glomerular injury, known as the acute glomerular nephritis, is caused by an abnormal immune reaction. Abnormal immune reaction that damages the glomeruli. Many of the glomeruli become blocked or become excessively permeable, leading to a decrease in the renal function. The tubular epithelial injury, that is the tubular necrosis, may be because of severe ischemia, that is the inadequate supply of oxygen and nutrients to the tubular epithelial cells. Or tubular necrosis may be because of poisons, toxins, and medications, especially ingestion of heavy metals. Post-renal acute kidney injury. Multiple abnormalities in the lower urinary tract can block urine flow and lead to acute kidney injury even when the kidney's blood supply and other functions are normal. The causes of post-renal acute kidney injury include bilateral obstruction of the ureters or renal pelvises caused by large stones or blood clots, or bladder obstruction or obstruction of the urethra. With this type of renal injury, normal kidney function can be restored if basic cause is corrected early. However, if the obstruction lasts for longer, it can lead to irreversible kidney damage. Now let's study physiological effects of acute kidney injury. A major physiological effect of acute renal failure is the retention of water, waste products of metabolism, and electrolytes in the blood and extracellular fluid. This can lead to water and salt overload, which further causes edema and hypertension. Other physiological effects are hyperkalemia or metabolic acidosis. Let's now study the chronic kidney disease, which is the second main category of severe kidney diseases. Chronic kidney disease is defined as the presence of kidney damage or decreased kidney function that persists for at least 3 months. It is associated with progressive and irreversible loss of functioning nephrons. The important causes of chronic kidney disease include diabetes mellitus, hypertension, atherosclerosis, tuberculosis, glomerulonephritis, nephrotoxins, and urinary tract obstruction. Despite the wide variety of diseases that can lead to chronic renal failure, the end result is the same, that is, a decrease in the number of functional nephrons. The progressive loss of nephron may lead to a condition called end-stage renal disease. End-stage renal disease. In end-stage renal disease, a person must receive dialysis treatment or undergo kidney transplantation in order to survive. This figure shows the vicious cycle that can occur with primary kidney disease. Loss of nephrons because of disease may increase pressure and flow in the surviving glomerular capillaries, which in turn may eventually injure these normal capillaries as well, thus causing progressive thickening called sclerosis and loss of these glomeruli. The causes of chronic kidney disease can be classified into three main categories. Number one, injury to the renal vasculature. Number two, injury to the glomeruli. And number three, injury to the renal interstitium. Now let's study these causes one by one. Injury to the renal vasculature. Many types of vascular lesions, that is vascular injuries, can lead to renal ischemia and death of kidney tissue. The most important of these vascular lesions are due to atherosclerosis, fibromuscular hyperplasia, nephrosclerosis. Out of these, benign nephrosclerosis is the most common form of kidney disease. It occurs in the smaller interlobular arteries and in the afferent arterioles of the kidney. Nephrosclerosis begins with leakage of plasma through the intimal membranes of smaller interlobular arteries and afferent arterioles of the kidney. This leakage of plasma causes fibrinoid deposits to develop in the medial layers of these vessels, followed by progressive and gradual thickening of the vessel wall. There is constriction and occlusion of blood vessels. The kidney tissue becomes replaced by fibrous tissue. When sclerosis occurs in the glomeruli, the injury is referred to as glomerular sclerosis. Glomerular sclerosis. Now keep in mind that the frequency and severity of nephrosclerosis and glomerular sclerosis are increased by hypertension or diabetes mellitus. The second important injury or lesion causing chronic kidney disease is injury to the glomeruli, known as glomerular nephritis. Chronic glomerulonephritis can be caused by diseases that cause inflammation and damage to the capillary loops in the glomeruli of the kidneys. In contrast to the acute form of this disease, chronic glomerulonephritis is a slowly progressive disease. It may be primary or secondary to systemic diseases. In most cases, chronic glomerulonephritis begins with accumulation of antigen antibody complexes causing inflammation and progressive thickening of the glomerular membranes. And gradually the glomeruli are replaced by fibrous tissue and are unable to filter fluid. I end today's lecture here. We will continue with the study of chronic kidney disease in the next lecture.